Hello, my name is Yejin Hong. I'm a medical student at the University of Calgary, and our team is here to explain age-related macular degeneration, or AMD for short. This presentation is also intended to draw a connection between ophthalmology and geriatrics. So let's dive right in. People often say that the eyes are a window to the soul, and it is also true that by observing the eyes, you can spot a lot of signs of systemic medical conditions. Unfortunately, as the body ages, its ability to maintain homeostasis also diminishes, and there are a degree of deterioration in various degrees of the bodily tissue. The eyes are not an exception to that. They also undergo changes that is normal for aging. So let's go through them one by one. First of all, the muscles surrounding the eyes atrophies. So the eyelid muscles, specifically levator palpebrae superioris, weakens and ptosis occurs, or drooping of the upper eyelid. Because the body powering the eyelids and keeping it open has decreased in strength, entropion, or inward turning of the eyelashes, can also happen. The general tone and the integrity of the eyelid skin, as well as the tendon underneath holding the shape together, also tends to become loose, and that exacerbates the appearance of ptosis. The eye itself, when you're trying to look left, right, up, or down, may be restricted in its movement, and senior population may have to use more of the head turns to accommodate where they want to look. The conjunctiva, which is a layer overlying the sclera, is also thinned, and the sclera itself, which is that white part of the eyes that you see, increases in its transparency. Therefore, you'll see more bluish color in the sclera rather than its usual white. The lacrimal gland, as the body ages, gets tired and is not as efficient in producing tears, and therefore dry eyes may be common in senior population as well. Overall, eyes may appear sunken in, and this presentation is called enophthalmos because of the fat shrinkage within the orbits of the aged population. The fat usually insulates the eyes and cushions it from potential trauma and impact, but it does shrink over time. Moving on to the anterior segment of the eyes, you may be able to see the white ring at the limbus, or the border between cornea and the sclera. This is called arcus senilis, and it's a benign sign observed in aged population. The retina also has decreased number of photoreceptors available, and resulting in decreased density and also diminished contrast sensitivity. Maybe it's because of this that the pupil response to light is lessened. Finally, vitreous, or the gel within the body of the globe, shrinks over time. As we age, this is a natural phenomenon that is noted. And one harmful consequence that can come from this is that as the vitreous shrinks, it can also pull the retina behind them, and this can cause retinal tears and detachment in severe cases. One condition that is often observed in senior population is age-related macular degeneration, And this condition is age-related, so as a person ages, there's a progressive degeneration of different layers of the retina. And specifically, we have noted on the slide retinal pigment epithelium, or the RPE, the Bruch's membrane, which is the innermost layer of the choroid, and finally choriocapillaris, which is a layer of capillary system immediately adjacent to Bruch's membrane. You are probably wondering what those three layers are, and the fact is that the retina is made up of many different layers that all help us see. First, when you look straight at the retina itself, as you can see in the top right corner picture there, there is a fovea and the macula. These regions have the highest concentration of cones and is responsible for central vision. The macula here is also included in the name itself, AMD, age-related macular degeneration. On the nasal side of the retina, there's the optic disc, which is a point of exit for the ganglion cell axons. Light rays that converge to this site, ironically, you wouldn't be able to see. It is often called a blind spot. When you put your fingers right in front of your eyes, so right in front and between, and gradually move the finger away from you, then there will be a point at which you won't be able to see your finger. And when you move further, you will be able to see your finger again. That point where your finger disappears is the distance at which the light from your finger converges on your optic disc. There are also a lot of vessels of the retina that you will be able to appreciate on fundoscopy, and both the veins and the arteries will be able to you will be able to visualize on the exam. As you can see, there are a lot of layers in the retina listed there below. I'll explain the three layers that we talked about in the previous slide. The retinal pigment epithelium is the first site to be affected in the case of AMD. This retinal pigment epithelium layer has a lot of functions, including transport of nutrients and water, absorption of light, as well as protection against photooxidation. Photooxidation is a production of highly reactive molecules from stimulus of light. And another function is phagocytosis of a shed photoreceptor membranes. The next layer, Bruch's membrane, serves as a barrier between the retina and the choroid. Lastly, the choriocapillaris is a series of capillary network that nourishes the photoreceptors, the cones and the rods, and also gets rid of waste. And here are more helpful diagrams to help you understand and orient you to the anatomy of the eye. Feel free to pause the video and have a better look. There are two types of age-related macular degeneration, the non-exudative kind, or the dry, and the exudative or the wet AMD. The dry AMD can develop into the wet AMD. We will touch upon that later. Dry AMD is caused by a natural increased permeability in the retinal vasculature with age, and this causes leakage of any waste products that the blood is circulating around the body in the process of eliminating them. These waste products present as drusen, or little yellow spots in the retina, and because this does get in the way of the incoming light rays, it can interfere with vision at the macula. And as mentioned in the previous slide, dry AMD can develop into wet AMD. The drusen disrupts the Bruch's membrane, which we talked about before as the border between retina and the choroid. And the reason there was a barrier there was to prevent blood vessels from growing into the retina. Blood vessels are helpful for a lot of things, supplying every tissue in our body, but from the perspective of sight and the retina, it is not good. Now that the Bruch's membrane has been disrupted by drusen, the blood vessels now have an access to new layers of tissue and the hypoxic environment. That is the interior of the eye. The blood vessels then are stimulated to grow through the membrane and into the retina. This is known as neovascularization. This is a serious threat to vision because the neovascular network is not as sturdy as a standard normal vasculature. This neovascular network can leak a lot, and it is prone to hemorrhages. Edema from such a network which is the leakage of fluid to the inside of the eye, can cause unwanted refraction of the incoming light rays, and which results in obscuration and disproportion of vision. Drusen can also appear in the retina in people who's normally aging and do not have AMD. That is why we have a specific criteria for determining if there is AMD and also how severe the condition is. For that, we look at the Beckman criteria and the AREDS, or Age-Related Eye Disease Study score. And you can see the chart here. It's pretty specific depending on the size of the drusen, the number, and the presence of pigmentary changes. In advanced stages, as I mentioned before, there are neovascular changes and atrophy as well. There are quite a few risk factors with regards to age-related macular degeneration. The most significant, as implied by the name of the condition, is age. Greater than 75 years generally presents a greater risk factor of AMD. Ethnicities. If you're Caucasian or have a lighter iris color, you're predisposed to the high risk of AMD. If someone has a family history of AMD, there is a genetic predisposition to this disease as well. Hyperopia is a refractive error where the light converges behind the retina, and it's actually easier to see things that are far away than focusing on things right in front of your eyes. Hyperopia, for example, if you have a very weak refractive power with regards to your cornea and the lens, or if the eye itself is shorter instead of long when the length is measured from the apex of the cornea all the way back to the retina. That could be a higher risk factor. That could be a risk factor for AMD. Lifestyle choices such as cigarette smoking, hypercholesterolemia, which can have genetic factors as well, and cardiovascular disease, as well as hypertension. These can all raise the risk for developing AMD in a patient. Also, statistically speaking, females tend to get more AMD than males. In terms of symptoms in dry AMD, the early stages are asymptomatic, and gradually there is decreased vision due to waste products obscuring the path of the light. And advanced stages will present with scotomas in the central or pericentral regions. Remember that AMD is age-related macular degeneration. Macula is responsible for central vision, and scotoma is an area with diminished or entirely degenerated visual acuity. Wet AMD as a macular degeneration can also present with central scotoma. It can also present with something called metamorphopsia. This is warping and distortion of vision because of the fluid on the inside of the eye. There are specific signs that you may be able to observe in a patient with AMD. In dry AMD, the patient may have decreased visual acuity. When holding an Amsler grid in front of a patient, the description of the grid may be abnormal. So, to the patient with AMD, the grid may not be continuous throughout. There may be small localized areas where the vertical and the horizontal lines are not present. Upon observation of the fundus, you may be able to note small yellow spots or drusen. On the OCT, you will be able to note the atrophy or the thinning of the RPE layer, and the foveal reflex overall will be blunted. In wet AMD, advanced stages, there can be choroidal neovascular membrane and lipid exudates. Subretinal or intraretinal fluids, including hemorrhages, can be noted upon fundus exam, and RPE tears even may be noted. Drusen is not a characteristic finding in AMD. As such, patients presenting with the symptoms and signs that we just discussed may have entirely different diseases, and thorough workup is required. The differential diagnoses commonly considered for AMD is dominant drusen and pattern dystrophy, which is caused by a buildup of lipofuscin, Best's disease, which is vitelliform macular dystrophy, Stargardt's disease, which is a hereditary macular dystrophy, drug toxicity with a lot of ocular side effects, central serous retinopathy, and angiostreaks and myopic degeneration. For a patient with potential AMD or risk factors for AMD, a complete ophthalmic history is warranted. This is either to confirm AMD or to rule out other important diseases of the eyes. This includes any ocular medications, ocular conditions the patient may already have, and family history, surgical history, and also general systemic medical conditions and medications are also important to note. Vision's pupil and pressure before starting any slit lamp exam, and also observe each layer of the eye from the anterior to the posterior segment with the slit lamp exam. Then you can dilate the eyes of the patient and perform a fundus exam. In terms of investigation, you can look into FA, fluorescein angiogram, on which the presence of drusen can be detected. Fundus autofluorescence can evaluate areas of geographic atrophy that looks dark, and on the OCT, It can also identify areas of drusen and atrophy of the retinal layers. There are a variety of treatments available for people with AMD so that they could resume a high quality of life. For dry AMD, we generally follow with the Amsler grid every day and examine every 6 months. For category 3 that we talked about, which falls into intermediate AMD, remember this is an extensive intermediate drusen, or one or more large drusen, which is more than 125 micrometer in diameter, or non-central geographic atrophy. For category 3, we can use high-dose antioxidants and vitamins. Some vitamins that are included here is vitamin C, vitamin E, and also lutein is included in the mix, zeaxanthin, zinc, and copper. Smokers, it would be helpful to note that smokers should not take beta carotene at high doses because of their increased risk of lung cancer. For category 1 or 2, 1 is less than 5 small or less than 63 micrometers diameter of drusen, and category 2 is mild AMD, which is a multiple small drusen or single or non-extensive intermediate. Intermediate is 63 to 124 micrometers in diameter. Drusen or pigment abnormalities found on the retina. So take a breath. For category 1 and 2 or strong family history, consider supplementing the above treatment for category 3 with lower dose of antioxidants. So category 3, high dose antioxidants. Category 1 and 2, lower dose antioxidants. Low vision aid may also be important as well for daily functions. For wet AMD, we use laser photocoagulation and anti-VEGF. Specifically, there can be a focal laser photocoagulation with argon green or yellow or krypton red laser that can be applied. The point of this is to hopefully seal any leakage and prevent neovascularization. Anti-VEGF agents, we have 3: Avastin or bevacizumab, Lucentis or ranibizumab, and Eylea, which is aflibercept. And you'll see in those bullet points that I have written the schedules of these anti-VEGF agents. Low vision aids and blind services can be provided to some people with wet AMD. The prognosis of dry AMD is good unless there is a central geographical atrophy or exudative AMD. Whenever the central vision is interfered, the prognosis is not as ideal. Severe visual loss can occur in 12% of patients with dry AMD. For wet AMD, the long-term effects are not really known. The choroidal neovascularization may recur or persist, and the risk to fellow eye also exists. And the other healthier eye without the AMD, the risk of that eye developing CMV is 4 to 12%. Okay, and here is a summary slide of everything we've talked about in this presentation about age-related macular degeneration. For some of us that prefer a flowchart, step-by-step presentation of such a summary, here's that 2. And here are the links, the resources that we used. And here are the resources that we used for images. Thank you for watching this video.